All right, good evening, everyone. Today we are going to be discussing malignant hyperthermia. So first, what the heck is it? Despite me being an ICU nurse for a few years, I have never seen malignant hyperthermia. So it is a hypermetabolic state, potentially fatal reaction to triggering agents. It has a genetic component. If you have a defective oryanidine 1 receptor or RYR in the skeletal muscle, sarcoplasmic reticulum. So, some MH pathophysiology. It's uncontrolled release of calcium causing um, muscle contraction. There is an increase in energy and oxygen consumption, leading to elevated levels of CO2 causing acidosis. Due to the energy consumption, ATP is being depleted, leading to cell death and also elevated levels of potassium. So as you can see here, the RYR1 is mutated, and it's opened when a triggered substance has been detected and there is a rapid efflux of calcium. So there are three major areas where we're going to see signs and symptoms of MH. First, muscular. So there's going to be muscle rigidity, which makes it very difficult for oxygenation, ventilation, and intubation. And there's going to be widespread muscle rigidity throughout the whole body and rhabdomyolysis due to the sustained contraction. Metabolic, we're going to see elevated temperature and end tidal and a rapid decrease in SpO2 and mixed acidosis due to CO2 and lactic acid. All right, cardiovascular, we'll see tachycardia, dysrhythmias, hypertension as an early sign due to SNS outflow, and hypotension as a late sign due to accumulation of CO2 and lactic acid. So let's quickly put it all together, and this is how we're going to see it when we have our patients in the OR. So looking at our heart rate that's elevated, our end tidal that is 90, our low SpO2, and our elevated temp combined with muscle rigidity, that acidosis we're going to see on our ABG, and the end tidal is going to remain elevated despite interventions. So we have early and late stages of MH. So it's really important to recognize it in its initial clinical phase, because the quicker that we are able to treat it, the better the patient outcomes are. So we're going to see that trismus, that muscle rigidity, that rapid increase in end tidal CO2, that tachycardia. Late signs are going to be fever, hypotension, and bradycardia. All right, so what are some things that can trigger MH? So with that genetic component that we talked about earlier, in conjunction with receiving a triggering agent, our volatile anesthetics such as sevoflurane or our depolarizing neuromuscular blocking drugs like succinylcholine. All right, so how do we treat MH? We immediately want to stop the volatiles and stop giving any succinylcholine. We need to call for help and get that MH cart. The drugs that we need to treat MH are not going to be in the crash cart. We need to know in the OR where the MH cart is, so that way we can get it and get the patient the medications that they need. Hyperventilation with 100% FiO2, and give that dantrolene 2.5 mg per kg every 5 minutes of the max of 10. So dantrolene is going to be our primary medication that we give to patients who we think are experiencing malignant hyperthermia. Further management, we need to fix that acidosis by giving bicarb. We need to cool the patient down by giving cold IV fluids and ice packs. Correct that potassium with insulin and dextrose. Monitor any dysrhythmias with inotropes and antidysrhythmics. The patient will require Lasix as well to avoid any acute respiratory failure. We need to avoid calcium channel blockers, especially if dantrolene was given, because there could be cause a rapid influx in potassium. All right, now go ahead and take out your phone for me and put this number and website in your phone. This is going to be the malignant hyperthermia 24-hour hotline, and there is the website there as well. So, you've patient says they're susceptible, or you think your loved one is susceptible to MH. There are a couple different tests that are out there. One that is a little inconvenient, a little expensive, is going to be the caffeine halothane contracture test, which essentially is a muscle biopsy that the muscle is taken out and they put caffeine and halothane on the muscle to see if it contracts. I think there are limited diagnostic places that do this around the country. And there is also genetic testing. However, the genetic testing is not very sensitive. All right, a quick note here, especially when we go through our pediatric rotation, 1 in every 10,000 pediatric patients will experience MH, as well as 1 in every 40,000 adults. MH kills about 2 people per year. However, roughly 20 people die per year from lightning strikes. So you're more likely to get struck by lightning than to die from MH. All right, you guys, thank you.